Hello everyone, welcome to piyushmalik.com. Today we'll discuss how to interpret transcranial Doppler. I am not sure in any of the site, paid or free, till now in internet uh, is allowing you to do this. I don't find anywhere it is there. So this will be the first transcranial Doppler podcast which is free and it's telling you how to go about it. Now, transcranial Doppler uh, was popular in 80s, right? And suddenly uh, it disappeared. Nobody spoke about it. And why was that? You know, there is something wrong in the name even. You know, then what's new? So basically, what used to happen at that time, a Doppler technician used to come with a probe which was fixed like, middle cerebral artery blood flow would be found from left side earlobe or just above the temporal bone, 6 centimeter. So it was completely blind. The thing which has changed is now the point of care ultrasound is allowing us to see the middle cerebral artery or anterior cerebral artery or whole circle of Willis is visible now. Okay, now you will see and you will direct the pulse wave exactly to the point where you need to get those velocity on. All right, so this is number one. So what should be the name of the transcranial Doppler now? Now the different name which is should be used now is transcranial color coded duplex Doppler. So basically, we are seeing the things and doing it. So things have changed over a period of time. So the things which is being done now, it's more accurate, precise, and the velocity calculation, the blood flow velocity calculation is much more better now. So this is used for emergency physicians, can be used in ICU, in neurocritical ICU, for anesthesia, for any surgery which involves affection of brain. So let us go for indication. As I said, in the past there were different, present and future. Sickle cell disease requiring blood transfusion is a class 1 indication. All right. So there is ample of data now, evidence now that transcranial Doppler can prolong their life. How and why? We'll discuss about that. Assessment of the carotid endarterectomy, subarachnoid hemorrhage. This is also very high level evidence. Is vasospasm identification. In subarachnoid hemorrhage, vasospasm, whether your nimodipine is working or not, the patient needs to go to IR or you can manage with medicine. What did you do? We just give nimodipine and keep them in ICU, get ventilated, triple S therapy. There is a doubt again with the triple S therapy. So, all these things are changing. Now, stroke diagnosis as well as treatment supplement. I mean, treatment means you give all those lytics, thrombolytics, and you see exactly what is happening. So, how it helps in treatment is like you give the thrombolytics and see the middle cerebral artery which was blocked or stroked out is opening up, and this ultrasound beam has enough dispersing power. It probably there is a thought going on that due to nanotechnology the drug distribution in that blocked artery area is getting better. In CABG, diagnosing, preventing probably the air embolism, one of the very big ancillary test for brain death assessment in US is doing TCD. There is a clear cut sign called beacon sign in a particular type of pulsating cerebral vessels where the diastole is the issue. We'll discuss about that in the next slide probably. The brain death assessment, this is an ancillary test, has to be done, or if it is done, the diagnosis becomes very obvious. Assessment of grading of foramen oval, extracranial occlusive disease, vasomotor reactivity to carbon dioxide whether the brain is vegetative or still. So vasomotor reactivity testing, too many more potential, you name it. I mean, now if you can see the blood flow through the cerebral vessels, you can imagine, as well as the cerebral vessel structure, the flow inside it. Why not? So how to do it? So this is a video already posted in the website. You can.
Alright, this is transcranial Doppler examination demonstration. This is Warburg's phased array probe. Now we are going to put it over the temporal bone, which is supposedly the tallest bone of the body. Now the brain, and we'll try to locate the cerebral peduncles
Whatever you are seeing
or
inside,
and the
the next
mid-brain
slide I
area
will
where the
explain
subclavicular stays.
you are seeing.
So I'll put the color there, and once I put the color, then you can see a snake-like structure which happens to the middle cerebral artery, and I'll put Doppler over there, and I'll take a Doppler scan anywhere between the segments. So once there is the segment, is pulsating segment is there, and you have to take a Doppler recording. Then you press start, then you get the blood flow. Once the blood flow is obtained, you have to freeze it and the various calculation.
So this is the structure you have just seen. You can see in the middle of the screen two peanuts like structures together. You know what? Those are the peanuts like structure. One is a big thick arrow and a triangle. They are both pointing towards midbrain level. So it might be midbrain, pons, medulla, depending upon the angle of the probe you are using. If you are too down, it will be pons or down below. All right. So now this is the structure, and just in front of it, remember, lies the middle cerebral artery up either, I mean, subsequent side. So the probe is there in one side of the ear. So this probe is starting from up. So you will see the middle cerebral artery structures like this once, and it will be pulsatile structure, right? What you will do is you will take the pulse wave and put it over that pulsatile structure like this. Okay. Now once you put the pulse wave over there, you will get a curve or blood flow pattern depending upon the disease the patient which he have. It will be different for different person. Now let us go what you will get. Now you will get this like systolic, one of the peak systolic and a diastolic flow. Now in this particular subject, it's normal subject. Now you see the peak systolic flow, it's somewhat around 70, right? And the diastolic flow, the upper limit is somewhat just below 40, right? If I enlarge the screen, it will be more accurate. You can take a graph and it will automatically, you do not need to do it. You put on the cursor wave on, and it will calculate everything for you. All right. So based on this velocity, starting from stroke to sickle cell anemia to subarachnoid hemorrhage vasospasm, everything will be diagnosed and predicted. Now let's see, normally it is systolic peak is around 60 to 100 for a normal adult. Now what will happen in case of subarachnoid hemorrhage? Now this flow velocity will increase to a limit. Can you guess? It will be more than 200, 250 centimeter per second. Here it is 70, right? When there is vasospasm, the same amount of blood will flow through a narrow vessels with a very high velocity. Now this is number one. Now, if it is velocity is increasing, then what are the other things we can diagnose? Like, in sickle cell disease, when the patient is going to be stroked out, his velocity goes very high. You monitor every month once, you see that they are ranging that normal, I mean above normal, so it will be their normal blood flow would be around 100, 150. Now when they reach around 200, 250, that means there are lots of sickle cell has happened. I mean, you have to transfuse a unit or two or treat with IV fluids or whatever. Like, they should not stroke out. This is how it became a class 1 indication for treating and managing sickle cell disease patient, those who die early age. So they're in the use of ultrasound, I mean transcranial Doppler, their lifespan can be increased. At the right time, you can transfuse a unit or two of blood, then the sickle cell in their body will decrease at that period of time. In this way, you can prolong their longevity. Now, what will happen to the stroke? In stroke, distal to the stroke area, there will be a decrease in systolic flow. And at that systolic, this is a very complex thing. We'll go one by one. In many of those, I have all the categories starting from brain death to stroked out to hemorrhagic stroke to ischemic stroke. Every slides are there. When we start the paid version, we'll put all of them. All right. Now, what you are seeing here is, suppose a diastolic, what that is, which spoke about bit about systole. Now let's speak something about diastole. In diastole, which is around here less than 40, around 35, what will happen in brain dead patients is the diastolic flow is the flow where the energy, I mean, this is simply, this diastole will go down, 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 and it will become flat. All right. In completely brain dead diagnosed, which is the ancillary test or indicator, is the reversal of diastolic flow. The diastolic flow, instead of being positive, it will become negative. Systole might remain the same or high or whatever. That is known as beacon sign. The pulse lights on and off. So basically, there will not be any diastole. Rather, it will be negative in brain dead patients. Okay. So how to interpret? General principle remains the systolic and diastolic value for each vessels: middle cerebral artery, anterior cerebral artery, ophthalmic artery, posterior. So it has got some value, average value, and in vasospasm, flow increases to a very high velocity. So that's how you get to know that your patient is getting vasospasm from subarachnoid hemorrhage or any stroked out or stroke opening up after lytics. So basically, there will be velocity changes will be there. Okay, lower the diastolic flow, more is the pressure inside the brain. Normally, in brain dead patient. All right. So there is a caveat to it. You have to learn due course of time. When you get better in transcranial Doppler, you will have all these variations. For a simple term, it's basically diastolic low is bad and systolic very high is bad, and diastolic reversal towards the negative is happening on brain dead patients. Okay, diastolic reversal is a sign of brain death. Okay, so what you are going to read now? Now, there is a very good mathematical correlation. There are three indexes there. They have been challenged, they have been accepted, they have been, I mean, rejected. Now, after doing this, what do you call this, color coded Doppler, the things are becoming better and better every day. Three things you have to read: pulsatility index, resistive index, and Lindegard index. This is what you read it. Those people, those who will read and revert back through my website piyushmalik.com, let them know, at least if there is few people, we can do how to do all these things: pulsatility index and sensitive, I mean resistive index and Lindegard index. I hope you have gone through that ocular ultrasound. Here also you can do the same TCD. In somewhere I have shown it like this. You can get those as a ophthalmic artery is a intracranial structure, so blood flow in ophthalmic artery, also can give a fair idea about the blood flow inside the brain. So you get these kinds of velocity and in ocular ultrasound, ocular TCD. So if in old days when the bone is calcified, you cannot find much of view, so you can do a ocular ultrasound. That means we are talking about 100% of the time. So we are getting TCD. We are talking about TCD in adult. So everything is possible. So now it's up to you. Another problem was there that TCD was done by a technician, all right, and being a doctor, probably, I don't know, probably you guys have more understanding. So interpretation power of a physician might be better. So that is how this is getting revert back to mainstream. All right. Thank you very much, and we'll discuss the details, the nitty gritty of each and individual cases in due course of time in the website. Thank you very much.